Today's class will be on blood and blood products. Regarding blood and the blood products, every drop counts. Every drop is very important. See, now it will not be like a regular class. You imagine a patient. The patient is 28 years old. She is second gravida, para 1. She has one child and she is conceived the second time. After her normal vaginal delivery, after 15 minutes, she suddenly started bleeding. Estimated blood loss is approximately 1200 ml. If you check her blood pressure, it is 90/60 and the heart rate is 120 beats per minute. You check her saturation is also dropped, it is 95%. You do a clinical examination, you touch the uterus and see the uterus is not contracted, the uterus is boggy. So, what will be the diagnosis for this patient? Any idea? After delivery, patient started bleeding. She is in shock. What is the diagnosis? Postpartum hemorrhage. Very good. So, you should know the definition of PPH. Initially, the definition of PPH was such that the blood loss of 500 ml in vaginal delivery and 1000 ml in cesarean section. We called it as PPH, but 2023 WHO has changed the definition for PPH, that is blood loss of more than or equal to 300 ml with clinical signs of shock. Clinical signs of shock matlab, see if the heart rate is more than 100 or if the BP is reduced, BP less than 100 or shock index if it is more than or equal to 1. If you see the last patient, the BP is obviously it is less than, diastole is less than 90, heart rate is more than 120, so there is signs of shock. And estimated blood loss, it is 1200 ml, it is more than 300 ml. So, it correlates with the diagnosis. This is a PPH. In that patient, what should be the goals? We should try to resuscitate the patient. The BP has fallen, so we will have to give crystalloids and blood to replace the blood volume. You will give RBCs in the, you will give packed red blood cells so that you will maintain the tissue oxygenation. You will give platelets, FFP cryoprecipitate to prevent coagulopathy, and you will try to prevent and treat hypothermia, acidosis and hypocalcemia. Whenever you detect a massive hemorrhage or bleeding, first thing what you do is try to detect it early and you plan for blood transfusion. When you plan for blood transfusion, at the same time you call for help also. You will tell the radiologist, anesthetist and the intensivist that you are going to transfuse the patient and the patient is in an emergency. This is WHO guidelines or strategy for PPH. See, it is E motive. E stands for early detection, M for massage of the uterus, O for oxytocic drugs. Oxytocic drugs are the drugs which makes the uterus contract. For example, oxytocin or misoprostol. T for tranexamic acid, we give IV fluids and then examinate and escalate. But the WHO has given this strategy throughout the world, but this will not stand for India because Indians are already anemic. You check half of the batch girls, you will be definitely anemic, your hemoglobin will be less than 10 only. So by dietary source only we are anemic. So this doesn't stand for us. So we should be B motive. B, we should arrange for blood products initially and then we should go for the E motive strategy. So what we will do is, according to the E motive, B motive strategy, for that case we would have given uterine massage, oxytocin, tranexamic acid and we would have transfused PRBC and 2 units FFP and platelets. So what we have got the outcome, the bleeding would have been controlled, hemodynamically the patient is stable and we can discharge her after 5 days. Blood is a specialized circulating tissue which has blood cells and plasma. It can be divided into cellular components and plasma components. If you see the whole body, 8% of the body fluid is composed by blood. In that blood, 55% is plasma and the rest 45% is the formed elements. From the plasma, you can get proteins and other solutes, which makes up 91% of water in the plasma, and in formed elements you get platelets, WBCs and RBCs. You should know what is whole blood. Any blood, after the blood donation, you are taking that blood, and if you are using a cryopreservative, we call it whole blood. Blood components are the components which which are separated from the whole blood. For example, from the whole blood only you get packed red blood cells also, plasma also, fresh frozen plasma, or platelets or cryoprecipitate only. So that are called blood components. Plasma derivatives are substances which are manufactured pharmaceutically. For example, albumin. So from the whole blood cell, you can get cellular components, plasma components and plasma derivatives. For example, red cell concentrate, leukocyte reduced red cell, platelet concentrate, you have FFP, single donor plasma, and you have albumin and things. This chart is showing, the first one shown is the whole blood. So if you take a whole blood, just after, for example, when a person is donated blood and you have added a preservative so that it will not close, that will become a whole blood. From the whole blood, what you do a centrifuge. You do a fast centrifuge. After centrifuge, RBCs get separated, that we call it as PRBCs, packed red blood cells, and the rest is the plasma. From the plasma, you again centrifuge. From that, you get fresh frozen plasma and platelets. Fresh frozen plasma, when you again centrifuge, you get cryoprecipitate, albumin and other things. Understood? So this is how a whole blood looks. It is indicated in patients who are actively bleeding and who have lost more than 30% of blood volume. More than 30% of blood volume means she has lost everything mostly. She is in a stage 3 shock. She has lost RBCs, she has lost plasma, she has lost clotting factors. So we try to give whole blood for the patient. Indications will be RTA trauma, major surgery, exchange transfusion. In cardiovascular bypass surgery, we use whole blood. But in obstetrics point of view, we don't use that much. We use PRBC so much. It is usually stored in 2 to 6 degrees Celsius. It can be stored for 21 days for CPD. CPD is a preservative which is used. 35 days for CPDA. This will be an MCQ for you. When will you not give whole blood? See, this whole blood has 450 ml. You are trying to transfuse 450 ml just like that. In patients like chronic anemia or in cardiac renal patients, this will cause circulatory overload. Suddenly when you give this much amount of blood, the heart will not take it. So they can go in for failure or pulmonary edema and things like that. So we should not give whole blood in that patients. Before transfusing whole blood, you should check for ABO and RH incompatibility. You should see if you should transfuse blood accordingly. If for A positive patients, you have to give A positive, for B you have to give B. If you don't have time to check for blood grouping and typing, you give O negative. This is how a red blood cell concentrate is. This is how it looks. We call it as PRBC. We commonly call it as PRBC, packed red blood cells. So normal hemoglobin is 12 to 14 gram, but this packet has 20 gram per 100 ml. Per 100 ml it has 20 grams. If you transfuse this packet, hemoglobin will rise from 0.5 to 1 gram. After transfusing this packet, see if the hemoglobin is 6, you have given one packet, then it will increase to 7. If you have to post it for OT, you have to raise the hemoglobin till 9. So from 6 I have to give 3 more. This is also stored in 2 to 4 degrees Celsius. When will you transfuse PRBC? In conditions which bone marrow productions are decreased. In bone marrow only, the production of RBCs are decreased. In conditions like leukemia and aplastic anemia, in these conditions the production is only decreased, and in conditions with RBCs are destroyed more. RBCs are destroyed more in hemolytic anemia and thalassemia, in spherocytosis. In conditions like that, there is increased destruction of RBCs. So, in conditions which production is less and where there is increased destruction in actively bleeding patients like surgical bleeding and trauma patients. When will you transfuse a PRBC? In obstetrics. In obstetrics, when we have severe anemia, less than 7 gram per deciliter, we categorize the patient as severe anemia, we try to transfuse blood. When there is any hemoglobinopathies like sickle cell anemia, thalassemia, or in any obstetric hemorrhage. What is irradiated PRBC? Any idea? See, any blood products when you try to transfuse, no, it will try to cause an antigen-antibody reaction, or plasma has antibodies. This normally you consider when the donor's blood is transfused into a patient's body. Patient body has the plasma. That plasma will have an antibody. That antibody will go and try to attack the red blood cells of the donor. So, in certain conditions where there is more chances of this antigen antibody reaction, we try to irradiate the PRBCs. Irradiate the PRBC means we give radiations and we try to deploy or destroy the antigen component of the RBCs. So, in certain conditions like transplant recipients, when they have received a transplant of an organ, they are more prone for infections and they are more prone for antigen antibody reactions. In patients who are immunocompromised, who are on prolonged steroids, there is something called graft versus host disease. The graft will reject the host. See, I am transplanting a kidney to a donor patient. That kidney will reject the host. That is called graft versus host reaction. And in certain other conditions, we try to give it. When will you not give? In chronic renal failure, in nutritional anemia, because in nutritional anemia there is no point of transfusing blood. We have to correct the iron. When oxygen carrying capacity, when saturation is normal, you did not transfuse. What is MTP? What is MTP? Medical termination of pregnancy. But this is massive transfusion protocol. Okay, this will be in short notes for you. What is massive transfusion protocol? What do you call a massive transfusion protocol? When we replace the entire blood volume. I told you human body is 8% is composed of blood. When we try to replace the 8% of the body fluid, we call it massive transfusion protocol, or 50% of the total blood volume in 3 hours. Or if we try to transfuse more than 10 PRBCs in 24 hours, or if we try to transfuse more than 4 PRBCs in 1 hour. These are all the criteria for massive transfusion protocol. They can give which among the following is in massive transfusion protocol, and they can give ABCD like that. So, platelet concentrate. See, blood sample is withdrawn and it is tried to centrifuge, and that side the yellow part is the plasma and the red part is the RBCs and the cellular components. From that plasma part you get the platelet concentrate. Platelets you can store for 5 days only. One platelet pouch will have 15 to 20 ml only. So like I told, whole blood you try to centrifuge, you get red cells and platelet rich plasma, which we call PRP, and then again when it is hard spinned at 22 degrees Celsius, you get plasma and platelet concentrate. There are 2 types of platelet concentrate. One is SDP and RDP. Single donor platelet, random donor platelet. Single donor platelet money, the donor is a single person only. You get the platelet blood from the single person. Random donor platelet you get from 4 to 6 people and then mix into one pool, single pool. Single donor platelet will try to increase the platelet count more. If you give one platelet, random donor platelet count will be increased to 5,000 only. Say if the patient's platelet count is 55,000, I give a random donor platelet, the patient count will increase to 60,000. But in SDP it will raise to 10,000. So we prefer SDP only. Indications of platelet transfusion: whenever in any condition in which platelet count is reduced, for example dengue, malaria, DIC. What is DIC? If platelet count is less than 5,000, regardless of any clinical condition, we will try to transfuse platelet. 5,000 to 10,000, this I have highlighted because in obstetrics it is important. Unless the platelet count is less than 10,000, in a pregnant patient, we need not transfuse. If the platelet count is less than 10,000, then only we try to transfuse. This is because increased risk of bleeding, because pregnant patients are already prone for bleeding. Pregnancy is a prone it is prone for bleeding pregnancy. So if it is less than 10,000, we try to transfuse. And for major surgery, platelet counts, if it is less than 50,000 to 80,000, we try to transfuse. In certain conditions like thrombotic thrombocytopenic purpura, ITP, heparin-induced thrombocytopenia, we do not transfuse platelets. Why? Because the purpura, it is already an antigen-antibody reaction only. If you try to transfuse platelets, the antibody in that condition is against the platelet only. So the platelet will again get affected. It is waste of giving in that patients. Fresh frozen plasma. This is the plasma that is frozen within 6 hours of donation. It has labile and non-labile clotting factors, albumin, immunoglobulins, factor 8. Most of the clotting factors are present in this only. This is very, very important. Whenever we try to transfuse 2 or more packed red blood cells, we try to give 1 or 2 FFPs to compensate the coagulation factors. If the red blood cells are more and the coagulation factors are less, patient will there is again chances of dilutional coagulopathy. Now this we seen before also. In liver disease, why in liver disease we try to give? Because the coagulation factors are synthesized by the liver only. In liver disease, coagulation factors will not be synthesized, so we give fresh frozen plasma. In DIC, it has dilutional coagulopathy. In certain conditions where there are clotting factor deficiency, we try to give. Contraindication you should know when we should not give. When patient is on blood volume expander or when patient is receiving albumin, we need not give FFP. When patient is having hypoproteinemia, we will not give. And cryoprecipitate, it has von Willebrand factor, fibrinogen, factor 8 and fibronectin. We should know what are all the components in cryoprecipitate. So as I told, it has von Willebrand factor, it will be used in von Willebrand disease. It has factor 8, so it is used in hemophilia A. These are the plasma derivatives. These are normally manufactured by pharmaceutical companies. For example, albumin, plasma protein fraction, SPEPS. These are normally used, these are called as blood volume expanders. See, when there is so much of blood loss that you cannot, suddenly if there is any fall in blood pressure, you have to try to maintain the blood pressure. If not, what will happen? If not, there will be acute renal failure. Blood supply to the kidneys are shut down. Then patient will go in for acute kidney failure and she will go into shock also. To prevent that conditions, we give albumin, volume expander. When we give albumin, the blood volume is replaced and the pressure is maintained. So, we try to give in nephrotic syndrome, ascites. So this is a gist. RBCs, our target should be, transfusing should be, if we should transfuse PRBCs when the hemoglobin is less than 7 gram per deciliter, Fibrinogen, if it is less than 2 gram per deciliter, we will try to give cryoprecipitate. Fresh frozen plasma, PT, we have to check PT and APTT. What is PT and APTT? PT, prothrombin time, and APTT. What is APTT? Activated prothrombin time. Activated plasma thromboplastin time. Why do we check PT and APTT? Before every surgery, we check PT and APTT. Coagulation, to check the coagulation time is normal or not. You know the clotting pathway. There is intrinsic pathway, there is extrinsic pathway. PT will check for the extrinsic pathway. APTT will check for the intrinsic pathway. So from that we can know clotting time, if it is normal or not. If the clotting time is increased, we try to give FFP because it has clotting factors. Then platelets, our target should be less than 50, if should be transfused if the platelet count is less than 10,000. Cross matching, it is very important because before transfusing any blood products, you try to cross match to prevent antigen antibody reaction. There are two types of cross matching. One is major cross matching, one is minor cross matching. In major cross matching, you take the patient's serum and it is matched with the donor's red cell, and in minor cross matching it is vice versa. You use the patient's red cell, donor's serum. See, sleeping pill are not candies. When we don't sleep, we try to eat sleeping pill, or people, they have a tendency to eat more sleeping pill, and that will cause cognitive impairment and things like that, and they get addicted. So too much of anything is good for nothing. Likewise, blood products, even if it is very, very important, it has got its problems also. So coming to the transfusion reaction, transfusion reaction can be acute or delayed. We will see about the acute transfusion reactions only. It can be immunological and non-immunological. Immunological reactions will be hemolytic transfusion reaction, non-hemolytic transfusion reaction, allergic, and TRALI. What is TRALI? Not the trolley which you push, TRALI, TRALI. Transfusion related acute lung injury. And TACO is transfusion associated cardiac overload. So non-immunogenic, you will have bacterial contamination, TACO, and hemolysis. Transfusion reaction can be acute or delayed. If it is less than 24 hours, it is acute. If it is more after 24 hours, it is delayed. What is the mechanism? See, when there is a antigen antibody complex, the plasma has the antibody, it will go and attack the erythrocytes, antigen component present on the erythrocytes, that will activate this complement system. Complement system C1 to C9 is activated, which causes lysis of RBCs. When RBCs is lysed, there will be hemoglobinuria and hemoglobinemia. The RBCs are passed in urine, destructed. Patients with reactions will have fever, anxiety, they might have chest pain. It has a triad. Patient will have a fever, flank pain, and reddish urine. See, you are in final year right now. Next year, probably all of you will become interns. So you will only transfuse the blood for any patients. So you should know very well regarding these symptoms and all. You try to transfuse a blood, and within 24 hours she is having shivering, fever, and she is having hematuria, if she is having dark urine, if she is having flank pain, you have to see that patient is having a hemolytic reaction, and then you will have to try to manage. Sometimes it can be severe also, patient might also die. So it is very important. How will you manage this patient? The blood which is transfused, you have to stop at what point it is. You have to stop the blood transfusion. You will have to monitor the urine output, because there is the destruction happens in kidney also. So kidney also may be damaged. So you will have to monitor the urine output. You will have to give diuretics to ensure the blood is cleared. Kidney perfusion should be maintained, and DIC you should have managed. Febrile non-hemolytic transfusion reaction. This is non-hemolytic. Non-hemolytic, there is no hemolysis of blood, but there is only febrile reaction. Only patient will have fever and chills, but hemolytic reaction is not there. This is milder variant. Allergic reactions, patient can have allergy. It is because of the transfused plasma. Patient will present with urticaria. They will, after transfusing blood, they will complain of itching. They will have swelling of face, puffiness. There is edema. At certain times, they can have laryngeal spasm also. If patient is having laryngeal spasm or laryngeal edema, it is very emergency. You have to intubate, or you have to try to do a cricothyroidotomy, or patient cannot breathe. It is a type 1 hypersensitivity reaction. It is because of IgE. When there is anaphylaxis, you try to give steroids, you try to give adrenaline, you try to give antihistamines to control the body's immunity. Anaphylactic reactions are sometimes serious also. Sometimes they can cause death. Symptoms can be hypotension, loss of consciousness, dyspnea, wheezing, stridor because of laryngeal spasm. There can be abdominal pain and vomiting. So management, like I said, you have to give adrenaline, you have to intubate the patient, you have to treat the hypotension. What is TRALI? Transfusion related acute lung injury. How does it happen? Because of the leukocyte antibodies that are present in the plasma. When there is a predisposing condition in the patient's lung only, and there is a biological response modifier elaborated during the component storage. These three things, they mix and it causes TRALI. This condition is very similar to ARDS. You transfuse blood to a patient, and after 6 hours, patient is complaining of fever, chills, dyspnea. You check for her saturation. Saturation is dropped from 100%. Patient is having hypotension. You take the steth, you auscultate, and you can see bilateral crepes, or there is bilateral wheeze. That will be TRALI. It is very rare, but it will spontaneously resolve in 96 hours. It is not that severe mostly. It is because of passively transfused antibodies in donor plasma to HLA or granulocytes, which causes increased permeability of the pulmonary circulation with infiltration of high protein fluid. So because of the increased permeability, there is increased plasma osmolality. So protein fluid goes inside the lungs. It causes pulmonary edema like symptoms. So treatment, you have to give oxygen. It is not that severe. If hypotension, you have to give fluids, and vasopressors, diuretics are not indicated. Differential diagnosis, you need not know this. TACO, transfusion associated cardiac overload. It occurs mostly in old age patients whose age is more than 70, in infants, patients with cardiac or renal disease. Within 1 to 2, after 1 to 2 hours of transfusion, you have TACO. After 6 hours of transfusion, you have TRALI. These both are very similar. TACO has most cardiac symptoms, TRALI has more chest symptoms. So in this you have S3 gallop, jugular venous distension, central CVP is elevated, dyspnea, orthopnea. What is orthopnea? Bacterial contamination in blood also. So whenever you try to take blood, draw blood, you have to clean the area with spirit to prevent contamination of bacteria. Most commonest bacterial causing infections are Yersinia, Staphylococcus and Enterobacteria. Sorry, it doesn't come with a manual, it comes with a mom. So you will have to treat every patient like the way you treat your mother. That is very important. That will be the lesson of the day. Thank you.